Andy is very retiring soon.
Tomorrow she will be 65, yeah, Eddie?
It's not our age now to work in hospital.
It's recording.
और नहीं ऐसा करोगे तो हाथ लग जाएंगे ऐसा करके ना ठीक है ऐसे ही सोऊंगा
भैया मैं नहीं बना सकती तू सर मार
छोड़ दो एक मिनट ठीक है जैसे
So how do you go like a
if you want just roll it this side like that
okay
like that एक मिनट उसे डाउन
Okay, I just formally introduce myself. My name is Mohammad Zafar Warsi. I work in one of the hospitals in ICU as a staff nurse. And currently I'm just finishing my master's. And this is my thesis, and this is all about the project I'm just going to present. It will be very short presentation, so if anybody likes to have a look after or in the middle, you're more than welcome. Okay. Are you able to see?
Yes.
Okay. Basically, it's about implementing confusion assessment method in ICU in an adult general ICU. It's a change management project as a part of my master's, and I'm just going to present a very brief presentation about it. The objectives of the presentations, by the end of the presentation, the participants will be able to discuss the UK government policy context in which this project been submitted, define delirium, identify the risk factors of delirium, describe negative implications and poor patient outcome with regards to ICU delirium, discuss the prevention and management of delirium, know the rationale of monitoring ICU delirium and using CAME-ICU, like why it's very important to monitor ICU delirium in critically ill patients, understand the rationale of practice development project, and explain the stages of change process to implement CAME-ICU, discuss the leadership theories and styles to lead change. Describe author's personal reflection regarding project. The policy context. The government, the UK government has published a number of policy documents. The aims to release this, these policy documents time to time is just to ensure patient safety and prevent from harm and promote evidence-based practice. Transformation of practice or practice development is necessary because sometimes the things are just keep doing it, the people just doing it without having any rationale behind it or any evidence available. It is called a ritualistic practice. And what UK government has identified that an effective clinical leadership is very, very important to ensure these targets are achieved. Without an effective clinical leadership, it cannot be achieved. The policy documents I've just jotted down, few policy documents, which is, Department of Health release NHS modernization agenda in 2000, and then in 2001 building a safer NHS for patients, and then safety first, a report for patients, clinicians, and healthcare managers in 2006. Frontline care, the future of nursing and midwifery in England, 2010. and then Equity and Excellence, Liberating the NHS in 2010. Similarly, the Scottish government released the same kind of documents as well. The main focus is again the patient safety and evidence-based practice. At the same time, they have released a couple of documents which are focusing mainly on leadership, like delivery through leadership and leading better care. And better health and better care focused on all the dimensions. They have pinpoint what sort of care they are aiming for. ICU delirium is just an overview. It has been described and defined by American Psychiatric Association in 2000. It is a sudden onset, altered consciousness, change and fluctuation in cognition or mental status, disturbance in perception. It is caused by the effects of medical condition directly. Basically, it is just opposite to dementia. Dementia is a sort of chronic mental illness. And ICU delirium is just like sudden onset of all these altered mental status. Incidence. It is quite like prevalent in ICUs. And what are the common problem among patients with advanced age, which is more than 65 years old? People are more prone to have this. Intubated and mechanically ventilated patients, post-operative cases, history of cognitive impairment like dementia. For example, if somebody already have dementia and they go to the ICU, they are more prone to develop ICU delirium. If somebody have a history of alcoholism, they are more prone to have hypertensive patients. Renal and hepatic insufficiencies caused ICU delirium as well. It is up to 80% of mechanical ventilated patients suffering from ICU delirium, 50 to 70% of non-ventilated medical ICU patients, and 36.8% of post-operative cases as an average. The incidence of delirium depends upon the age of the patient, environmental settings, type of surgery, and other risk factors. There are three common types of ICU delirium. It's hyperactive type, hypoactive type, and mixed type. Hyperactive type, which is less common, but is like the prognosis is better because it presents with the patient presents with agitation, hyperactivity, and confusion, pulling the lines, pulling the catheter, and like climbing over the bed. So it is very easy to recognize, and it's just there and then been treated. However, the hypoactive type, which is very quiet type, which is most common in elderly, is inattention, withdrawal, and low mood. Patient not eating, drinking, just in complete, state of depression, and which is very easy to look over and very easy to be, under-recognized. Mixed type is present with the both types of pictures. Sometimes patient in hyperactivity, and then it goes into hypoactive type. Risk factors. These are the the precipitating factors or hospital factors like sedation, sedative type of medications. Patients are on mechanical ventilation, and they are sedated with propofol and all other medications. And these are medications which can cause easily high ICU delirium, like narcotics, anticholinergic drugs, and things. These are the more risk factors, like somebody running with infections like septicemia or septic patient. They are more prone to have somebody hypoxic or in shock. They are more prone to have this to be developed. Some kind of surgeries like orthopedic surgery, cardiac surgery, prolonged cardiopulmonary bypass, and non-cardiac surgeries as well. Environmental factors are very, very important in this scenario because the patient admitted from home and go into the ICU settings, which is very noisy, like environment, all the times more interruptions and alarming, and so it caused them emotional stress and pain, and multi procedures keep going on. Some like physical restraints and multiple lines, central line, arterial line, catheter, NG tube, and the tube which we use for which is called endotracheal tube. So these are the lines make them physically restrained, and this is what it provoke delirium, and it compromises sleep deprivation as well. Implications of ICU delirium. It is the evidence suggests that it is independent predictor of increased mortality, independent predictor of prolonged mechanical ventilation, and prolonged ICU and or hospital length of stay, and increased cost of care, because the patients remaining over there more rather than expected. Once they develop the ICU delirium, they are more prone to have prolonged mechanical ventilation, and they're having more time in ICU than normal, and this is how it increases the cost of care. And the more importantly, the effects of delirium may not be temporary, as it can lead to long-term cognitive impairment such as dementia. Like if somebody already have dementia, they can easily provoke delirium, but somebody already caused ICU delirium, they can go into, they can develop dementia in long run. So which is very, very dangerous thing. Prevention and management of ICU delirium. Non-pharmacological interventions and non-pharmacological intervention, it's prevention and then diagnosis of delirium as well. So the intervention can be divided into non-pharmacological intervention, which doesn't involve any medications, and then the other part is the pharmacological intervention, like they give some haloperidol to the patient as a medication. But non-pharmacological interventions are really, really important, because